from the Psych Hub Podcast Network.
And welcome back to the Burnout Antidote, infusing well-being into healthcare culture. I'm Paul Dager with my co-host,
Amy Pearlman, to be with you.
And yes, our topic for today is secondary trauma as a healthcare provider. And, you know, as I got to thinking about this topic, we may even want to broaden it to just exposure to suffering in general, that when we choose to go into this line of work, there's a recognition of, you know, people don't show up to the hospital dancing and singing, woo, glad to be here, that we're exposed to people maybe on their worst day. And this feels like an important topic related to moral distress and burnout because it's sort of foundational to this environment, this work.
That really stands out for me, Paul, because I was thinking about this as when you go into this field, especially as a social worker, people say, oh, what a gift. And I think, is it really a gift, or is this something that is a strength that not everyone has, or an exposure or a risk that not everyone has, or maybe it's all of the above?
You know, I have a different version of that you just brought to mind, that I'm a parent of a young man on the autism spectrum. And one of the things as a parent you hear, oh, you must be so special. It's like, no, I'm not. I'm human. And I think that does, we choose to go, I'm a parent of my son who I love and adore, and this is our life. I did choose healthcare, but that doesn't necessarily mean I'm special. But like you said, maybe I just have an affinity for this experience of being exposed to suffering and still human and impacted by it.
I love how you can give an example to something that I try to explain with words, but it really is a feeling to some extent. So thank you for that, Paul.
Sure. And before we get too deeply into this episode, I do think, again, I'm a definition guy here. And so recognizing trauma exists in two different forms. Primary trauma is where I'm directly impacted by the traumatic event. I'm directly exposed to it. And then secondary trauma is I'm one step removed, and I am hearing the story of the person who is exposed to it. And I do want to add this idea that while we differentiate primary and secondary, they're both a form of trauma that is experienced within the healthcare environment.
And I can see from those definitions how secondary trauma does feel like a higher risk for healthcare clinicians, almost like something you sign up for when you go into the work. Probably not the driving factor for why you want to do it, but certainly a component that you think about the exposures or the risks that you sign off on when you go into a procedure, you sign up for something, and this is certainly one of those for healthcare.
Yeah, agree. How about we jump into our story for today about a healthcare clinician who experienced some direct trauma?
Let's do it.
Okay.
Starting out as a hospitalist, my first year, this is, at this point, 14 years later, I still reflect on this a lot. I had a patient, she was in her early 20s, and this was back when H1N1 was all the rage. It was before COVID, and people were getting really sick from it, but certainly not like what we dealt with later on with COVID. And I was taking care of a young woman, beautiful, in her 20s. She taught music to inner city youth, so she's just a good person. And she'd had a small rash on her leg or on her backside that she'd been in the woods camping. And it was a little after Thanksgiving. And she was joking about how silly it was that she got the rash because she was out traipsing through the woods. And what I remember is that she seemed young and healthy and vibrant. And over the course of 90 minutes, I watched her fall apart. She became hypotensive. She became confused. She couldn't breathe. We called the ICU and we put her in the intensive care unit. And she was very quickly intubated. She was on maximum pressors. She had CVVH going for renal replacement. So multi-organ system failure. She was on all the machines. And The family was in there every day, and I would go in and check on her every day when I was on over the course of the Christmas holidays and the New Year's holidays. And they did everything. The hospital did everything. We did bronchoscopies, all the oscopies you could think of to try and figure out what was wrong with her. We sent tissue samples to NIH. We sent tissue samples to Mayo. We probably tested her for H1N1 a half dozen times and never figured out what caused her to go into organ failure. And eventually, after she'd been maintained in this state for a few weeks, hoping against hope that she would get better, family withdrew care and she died. And I remember going home and sitting on the couch with my wife and just crying because I couldn't figure out what had killed this girl. And 15 years later, I still don't know, but it still follows me just how quickly she went from healthy and talking to me to sick, and then later on to not with us. Not knowing what killed her has been frustrating me for over a decade, that seemingly indiscriminately this otherwise healthy young woman could die, and despite aggressive medical care at a top facility and the best doctors, we could never figure out what was wrong with her. And it just feels like that's the one thing we can do in medicine. Even if we can't always fix the problem, we can at least tell you what it is. We might not be able to cure the cancer, but we usually can identify and figure it out. This is something that has followed me. It's been very frustrating over the years.
I appreciated that story and think it ties into so much we've talked about so far in this series. Mm-hmm. Our colleague really was struggling with that need to act or to do versus to be. And I could hear that in his experience.
Yeah, I mean, the words that echoed in my head were powerlessness, helplessness, hopelessness. And on so many levels. I mean, first of all, that couldn't be a healer, and then secondary, couldn't even identify what there was to heal. Almost was a whole other layer of trauma, that lingering effect that at least I should be able to identify what I'm dealing with, even if I can't fix it.
I started to think about this in terms of how we define success for healthcare clinicians.
Oh, yeah, say more.
And this idea of saving lives seems to be this ultimate success. But if not saving lives, using the science to understand the situation.
Okay, understanding.
And that's what outcomes feel like in today's society to me. Mm-hmm. But having gone through a healthcare procedure myself as recently as yesterday, what was the best outcome to me was the person who was present for me in the room, who was accessible and who could sit with me. It was more around being than about the outcome, which did happen to be positive. Okay. But what does that mean for healthcare clinicians who experience trauma or loss, which we all do, if the definition of success is always saving that life or having an answer?
Right. So first of all, how are you doing? Are you
I'm good. Thanks.
I just have to ask. Okay.
Thanks.
I care about you, so I want to make sure you're doing
it.
all right.
I realize we didn't talk about that before this call either, but I'm doing just fine today.
Okay, sorry to get personal, folks, but Amy's my friend. So two thoughts come to mind on that. One is some of the research around there's a higher incidence of PTSD when someone experiences freeze as opposed to fight or flight. And it makes me think about, because fight or flight, you at least have an action that you're doing. And I think part of the secondary trauma may be you're one step removed. There's no action you can take to resolve the event. And how action is protective. And hearing you speak to this idea of if we can't act or do, being can be really restorative, but we're not all skilled in that. and how to provide this presence for ourselves and others.
That sounds out to me as well. I probably because I was thinking about my own experience and what this
Yeah,
journey of being has been as someone who
right.
myself, I tend to be a doer also.
Yeah, yeah.
I started to think about in the research I read that most healthcare clinicians cope through two things. One is
Hmm.
denial, and the other one
Okay.
is humor.
I can see both of those being quite active out on a unit or department. Yeah.
And the denial piece seems to be a function of what the healthcare system has set up in terms of
Hmm.
moving productivity, moving from one
Okay. Yeah.
patient to the next, to the next. There
Okay.
really has to be, I shouldn't say there has to be, because I'd love to create the world where there doesn't have to be. But in our current
Right.
system, it's a protective factor to be able to move on. I have to
Yeah.
block or freeze
Hmm.
or deny what
Hmm.
is happening to move to the
Hmm.
next stage. And that denial becomes a delay more
Hmm.
than it short term versus long term coping strategies here, right?
Well, exactly. Yeah. Short-term gain, long-term loss. And it reminds me when I used to do some work with nurses doing mindfulness programs, and we came up with a whole host of different ways to practice presence in between patients. So just washing your hands, walking from one doorway to the next, and how you can infuse these touch points so that you aren't so out of balance in action all day, which then lends itself to denial as the go-to tool. The other thing that comes to mind is I experienced hospice twice on the receiving end as a family member. And in some ways, it's like we do it really well at the end when there is this recognition that we're not going to fix anything. And I have found that the healthcare workers in hospice, the ones that are just really in their zone, are the ones that they exude presence. And they have clinical knowledge, of course, but I think we need to walk it back, that we don't wait till the end to bring this into how we deliver care.
Set different expectations.
Yeah,
And
yeah,
that stands
exactly.
out to me from the story we heard from our colleague, and also what you're
Right.
saying around hospice is the expectations to fix or solve or answer
Yeah,
set us all up to feel at best like a failure and at worst these
right,
traumatic symptoms.
right. And, go back to the research that there tends to be less experience or episodes of trauma by the frontline staff when they feel support from leadership. So, to all you healthcare leaders out there, you demonstrating presence and support goes a long way. Do not discount, even if you may feel powerlessness, you can still offer presence as well.
Us healthcare clinicians are driven to heal and help others. At PsychHub, we offer a wide variety of content that can support your well-being, help you find new creative and evidence-based ways to practice, and get inspired again. Whether you want to better understand depression, or you're interested in providing trauma-informed care, or you want to learn about navigating grief, our vast library of educational content has you covered. PsychHub offers curated continuing education learning opportunities on a variety of timely and relevant mental health topics and evidence-based interventions, geared specifically toward healthcare and mental health providers. These custom learning programs will empower you to support better mental health for patients, colleagues, and yourself. Learn more about our evidence-based mental health education opportunities at psychhub.com.
I love that. And I think that in combination with the touch
Mm-hmm.
points may lead us into what our takeaway activity is.
Oh, what are you thinking? What do you got?
So, what I was thinking about was taking together all of these when you're not feeling stuck in it,
Okay.
thinking about building a toolkit for what you may
Okay.
need when you are in that space. Because when we as a community pull together I'm trying to think of the right word here, but when we as a community pull together that toolkit or those resources so that no individual has to do it on their own.
Right.
And so that
common humanity.
we learn about how to support when it comes up and also have some time to think about what we may need. I think when a traumatic event happens to any of us at work or in our personal lives, and someone says, what can I do to help? We don't know how to answer that question. But if there is a menu or a toolbox of what to pick from, I think that could prompt someone to know what they need, or also prompt the community to know what they can offer.
Okay, I've got a couple ideas to take this one step further.
Do it.
One is, like on the playground when they have the buddy bench, and that I envision some type of buddy bench in the unit or clinic or department where you don't, if you need some support, you can just go sit there and not even have to say a word to make it, this is a safe space. And then if you're sitting on the buddy bench and you're feeling you got extra to give, then you go support your colleague sitting on the buddy bench. My second idea is to take this and post this toolkit idea and post it somewhere in the clinic or the unit so that you don't have to go looking for it in a binder or look it up on your phone. It's like out there for everyone to see. Because I think if you see it, then you're more likely to take action on it.
I started picturing that when you were talking about the touch points in moving from room to room. And healthcare settings are different, but it may even be a pop-up on your computer when you go between patients or a sign on the wall where it may say fall risk. It may also say, did you check in with yourself before you came into the room, or wash your hands and breathe for a moment.
Right.
Or over the sink. I started thinking about some of these touch point reminders being posted at various places.
Nice. And one more thing comes to mind if we're talking about trauma and not even full-blown PTSD. I mean, the data now that trauma sub-threshold is significant in the U.S. population. Please consider reaching out for help as well if you really start to find yourself impaired in your functioning, in your relationships, in your behavior, your mood. Whether your employer has an EAP option or some other way to get some professional help, you as a healer deserve to feel good and to feel well. So please take care of yourself.
I could not say that better.
Thank you. I'm feeling hopeful at the end of this one, and I'm hoping that people can pick up on that and then turn it into something.
I think there's some real value that we can all bring to creating a community where we can support each other, set realistic expectations, and be there for the successful days and be there for the more challenging days as well.
Yeah, agree. All right, next week, what do we got going on?
Experience.
I think I asked you that every week.
I know, but this week I looked it up in advance.
Okay, cool. Yeah.
Next week we'll be talking about experiencing mental health diagnoses as a healthcare clinician. We hope you'll join us to continue the conversation.
Yeah, thanks, Amy, and see y'all back next week.
Thanks, Paul. If you'd like to reach us, you can do so at podcast@psychhub.com. To be notified of new episodes, don't forget to like, subscribe, or follow wherever you're listening. And reviews are so helpful, so please do leave one if you can. It allows others to find us and to join along. The Burnout Antidote is executive produced and edited by Jacob Morrison. Research is assisted by Tekla Ross. Show artwork was created by Ornella Jangoli and Ashton Smith. A very special thanks to Juliana Castro, Alyssa Fackler, Trevin Stiegel, Andrea Womack, and of course, our pet, Pickles. The Burnout Antidote is a co-production from PsychHub and is brought to you by Janssen Neuroscience.